Assalamu alaikum. Please, doctor, confirm that you can hear my voice clear. Okay, great. So this is Tan with you today. I think most of you doctors attend with us our lectures before, whether you attended our course or you attended our free lectures. Just to tell you what will be our program for the lecture of today, we will start by one case of history station, and then we will have another case of station 5. Then Dr. Anada will be with us for a case of communication. Maybe we may change the schedule if Dr. Anada arrive before that. She will take the second case, and then we will take the third case. The first case will be, as I told you, the history, and my other case is very important as well, as I will discuss again an approach for the rash. Some part of the rash, how to ask about the rash and how to make the rash case easy. And we will discuss about the autoimmune stuff. So you need to, it will be an important topic. Actually, in one lecture, we just try to show you how we are approaching the case and what is the system we are educating the patients by. Just 5 minutes till all the number arrived. For now, what I want to tell everyone, some advices from a brother. Okay, I don't want you to be stressed with the paces. You need to enjoy studying paces. Paces is not the study that you need to read 10 books or you need to read from many sources. In the paces, if you have only one source and you have a good practicing, you will hit a score above 160. Alhamdulillah, thanks God, most of our candidates that sending me the results after their exam, alhamdulillah, Dr. Muhammad Bushra just get his result and it was 169 as we sent to you. And we have Dr. Ali, he got also 162. So alhamdulillah, as we said before, our objective is not to pass the test, our objective not to lose any mark. The other thing, what we are teaching in our course and in our lecture, it's not about the knowledge only, because the knowledge present in all the books. The point is about the game, how to play the game. The PACES is a game, a very limited time game. You need to know how to play it, how to utilize your time, how to catch the diagnosis. The problem in the PACES that I faced myself when I was studying for the PACES in some stage, that you know the knowledge, but you can't utilize it in this very little time that you offered in the exam. That's why I want every one of you to reach his diagnosis or to have his approach, and within 2 minutes or 3 minutes he will get the diagnosis and he will know exactly, because you don't have time to think in the exam. So it's a matter of game. So if you attend the PACES before and you didn't pass, don't lose the trust in yourself, because it is just about how to do it fast, not about your knowledge. Everyone who passed part 1 and part 2 in MRCP is efficient enough to pass 10 PACES exam, not only 1. So I trust your knowledge, and I know exactly how efficient and how potent are your knowledge, but you still want to practice how to approach the PACES and how to pass the stations. For the doctors who will attend this year, we will keep discussing our cases with the old system. For the doctors who is planning to attend the exam before 2019, we will starting from the course of October. We will start to educate and teach by the new, according to the new PACES system that we discussed before. Okay. Just a hint about our course in the last minute. We are giving about 14 to 16 days. It will be about 6 hours a day. We allow you to attend a recorded lecture. So you can request a link for the lecture that will be available for 48 hours after the lecture. So if you are in duty and you can't attend the live lecture, you can attend the recorded lecture. and this will be, you will receive the schedule before we start the course, so you can adjust your timing. For sure, attending the live lecture is totally different because you can ask your questions and you can practice. You can still ask your question through the WhatsApp and through the group. We make a Facebook group and WhatsApp group for every course. Okay, and alhamdulillah, most of our candidates, alhamdulillah, are super satisfied. And Dr. Mahmoud and Dr. Ahmed are the administrators, and they respond to your requests, and they will share for you the reviews for our course. So I want you to take a look. I know that it is not easy to choose which course we will attend and how will we prepare, but I advised you to start online course at least 1 to 2 months before your exam, because we have a lot of materials, and I advise to study my materials. So you need to have this material. Most of the doctors said, we hope if we attend your course 1 month before to know all the algorithms by heart. If you attend, you will, Dr. Mahmoud will send for you as well a link for our lectures, for previous lectures on the YouTube, so you can watch some of our approaches for blurring of vision, for joints pain. We have many free lectures on the YouTube, so you will understand how we teach the paces and how we practice the paces together. Okay, I don't want to waste your time. Then, so we want to start with the first case, and the first case will start with Dr. Rita. So give me a second. I will allow you to open the mics because. So Dr. Rita, can you open your mic if you are there? We have Dr. Rita and Dr. Ahmed.
Yeah. Yes.
Dr. Rita?
Yeah, I'm here.
Okay, great.
Yeah.
So now, please, other doctors, please don't open your mic because this will make disturbance in the voice. Then, now we will start by the history case. Usually in the history case, you have 5 minutes to prepare. We will give you 2.5 minutes. Then we will give you the same environment of the exam. Then I will discuss with you, asking you as examiner, and then I will discuss in this case, okay, then I will discuss the algorithm and the approach for the case. So if it came to you in the exam, you will be very ready for that, okay? So now I will start with you, Dr. Rita. You have 2.5 minutes, okay? Did you attend our course, Dr. Rita, or you attend a lecture with us before, or this is the first time?
I did. No, I didn't do the course, but I did a session like this before.
Okay, great. Okay, so you know the system. It is the same as the exam. So you see the case now. This is Mrs. Catherine Marks. She is 39 years old, and she is suffering from headache. So please, I will read it for the doctors, maybe some doctor driving or something. Thank you for seeing this lady who gives a history of severe headache, which become persistent recently. She had a history of headache since many years, but recently it is not responding to painkillers anymore. Routine blood tests, including full blood count, okay, your kidney functions and electrolytes and liver functions, all within normal. Please see and advise. Okay, you have 2.5 minutes, doctor.
Okay.
I want every doctor to prepare his approach to a case of headache, so you can add what you want. Okay, doctor, you can start now.
Yeah. Hello, I'm Dr. Rita. I'm one of the doctors here for today. You must be Mrs. Catherine, 39 years old, right?
Yes.
Okay. Nice to meet you, ma'am. I came to know that recently you have been bothered with some headache. So can you tell me a bit more about that?
Yes, doctor, if you can, please raise your voice.
Okay. Recently, I heard that recently you have developed some headaches. So can you elaborate on that?
Yes, doctor. Recently, I had severe headache, doctor. I am the headache woman. I have headache all my life, and I am suffering from the headache all the time. But actually, recently it become very severe, and actually I can't tolerate it anymore. So I start to be worried about what's going on, and I was thinking to change my doctor because I'm not responding anymore, doctor. So can you please help me with these symptoms?
Yeah, I'm sorry to hear that, and hopefully we can come to a solution at the end of the discussion. But when you said recently, can I ask for how long the headache changed? Over how long the headache changed?
Doctor, I was diagnosed with headache since 15 years, and for that I'm taking the medicine. There is some medicines I'm taking daily, and there is some medicines as well I'm taking in the when I have the severe attack. But now it doesn't help at all.
So can I check your medication list?
Yes, doctor, I'm taking what is called Indral. I'm taking the Indral daily, okay? And I'm taking what is called Relax, and sometimes I'm taking ibuprofen when I have the severe attack. But even when I'm taking recently, it doesn't help at all.
So may I ask how many days per month you may have this headache, or how many days per month you're taking these medications?
How many I'm taking every day?
Every day. And this has worsened for how long since?
Yes, my headache become very bad in the last 10 days, doctor. And it
Last
is
10 days.
increasing.
Okay.
Yeah, in the last 10 days, it's become very severe.
So this new headache, it's worse than before. But
Yeah,
where is it located? Is it in the front, back, or your entire head, or does it feel like a band-like sensation?
yes. Actually, the headache now is severe and affecting all my head, but I feel it more, doctor, in one side of my head. And actually, it is like in the back of my eyes and
Okay.
in my face as well.
On both sides, not on one side.
It is more on one side, and
Okay.
sometimes I feel it in the back. It is rare to feel it in the back, but sometime it be in the back of
So
my
so when is the pain most marked? Is it in the beginning of the day, or at the end of the day, or does it persist throughout the day?
head. Recently, it is every time, doctor, all the time in the day.
All the time. Okay, I'm really sorry to hear that. And does it goes anywhere?
This goes what?
Does the pain moves anywhere to your back, to your face?
Yes, it is in the face and the back of my head as well.
Okay. And if I ask you to score on a scale of 1 to 10, 1 being the lowest, where will you put the pain?
Yes, doctor, it's about 7. Sometime it is 8.
Okay. And what makes it worse? It is like bending forward, coughing, sneezing. Do you think it gets worse?
Yes, doctor. I found that while I'm leaning forward, yes, I feel the headache become like I feel that my head will going to explode. Okay.
Okay. Right. So for the first 15 years, the pain you had and the pain right now you're experiencing, so you think it's different?
Yes, I think it's different, doctor, because I know that the other headache was preceded by some symptoms, and I was able to control it when I'm controlling some stuff and controlling my
Mhm.
diet. But this headache, what I'm doing, it's still there.
And did you have a diagnosis for a previous headache?
Yes, they told me it's something called migraine.
Okay, right. And what medication were you on for that? You just showed me that. Was it the medication you're using for your migraine?
I told you I'm taking what's called Indra, the propranolol. I'm
Oh,
taking
yeah, right.
daily, and I'm taking what's called the Relax. Okay,
Okay.
this
And
I'm
for the
taking.
past last 10 days, do you think it's the same or is it worsening, the new pain?
It is increasing, doctor.
It's increasing. I'm really
Yeah.
sorry to hear that. Okay. Do
Yes.
you have any disturbance in your vision with that?
Have what?
Any disturbance in your vision?
No.
Difficulties with your
Yeah,
vision?
yeah, yeah. I have, yes, I have. Now I start feel blurring of vision. And actually, doctor, there is something weird happened to my eyes. I feel that my eyes like look a little bit puffed. I looks like have a sleepy eye.
Okay, right. And do you have any pain or movement of your eyes?
Yes, there is some, doctor. This in
And
the
do you have
last
any,
3 days, doctor. In the last 3 days, I have been in moving my eyes.
okay, any pain in any part of your body, any weakness in any part of your body, in your arms or legs?
Weakness?
Yeah.
No, doctor. No, doctor. But I feel general pain in my body, and there
Right,
is there is like excessive sweating I'm feeling everywhere in my body. I have like attacks when I feel very cold.
right. So is there a recent change in your weight?
Any what?
In your weight? Any recent change in your weight?
In my weight? No, doctor.
Yeah.
No.
Okay. And do you have any high temperature?
Yes, doctor. I have a high temperature started since 15 days.
15 days. Okay.
Yes.
That's before the headache, right?
Yes, there were no. It started at the same time with the headache.
At the
Actually,
same time.
yeah.
Okay. And have you taken your temperature at home? Have you documented it?
Yes, it was.
What
It
was the
was.
highest temperature?
Yeah, 39.5, sometimes 38.5.
Okay. And is there any particular part of the day where you get the temperature, or
Is what?
do you have does it vary? I mean, does it come anytime, or is
Yeah.
does it come
Sometimes, yeah. When I'm taking some medications to lower my body temperature, I'm taking what's called paracetamol. Then after a while, the temperature become high. Actually, I visited the doctor for that, and
Okay.
he told me maybe the problem in I have a problem in my sinuses.
Okay, right. I'm sorry to hear that. And
Mhm.
do you have any stiffness of your neck? Any pain in your neck on movement,
No,
on bending forward?
no,
Or
doctor.
any rash? Any rash anywhere?
No, doctor.
Any joint pain?
Joints pain. When I have
Okay.
the high temperature, I have all my joints hurts.
Okay. And do you have any change in your weight?
No, doctor.
Okay. Any change? What about your appetite?
It's not great, but not bad. When sometimes, with the high temperature, I'm not eating well.
Okay. And do you happen to see double?
As recently, yes, in the last 3 days, I see some things double.
Okay. Right. So do you recall any sustaining any trauma to your head?
Trauma? No, doctor, no trauma.
Okay. Right. Did you have any infection anywhere? Any rashes or any infections?
Uh,
Any
I told
back?
you that when I have this fever, I went to my nose and ear doctor, and he told me that I have problem in the sinuses.
Oh, yeah, yeah. Got
Yeah.
sinus, right. So what about your bowel habit?
My bowel habit is within normal.
Okay. And what about your water work?
Water work is okay.
Okay. And uh, apart from this, do you have any known medical illness?
No, doctor. Just the migraine.
The migraine. Okay.
Mhm.
Any recent travel or
No,
any
doctor.
long haul flight?
No,
So
doctor.
what do you do for a living?
What?
What do you do for a living?
Yes, doctor. I am accountant.
Okay. You're an accountant. And how's all this affecting your life?
Yes, too much, doctor. This headache. Last 10 days, I took sick leave from my work because I can't work. My blurring vision affecting my ability to see the numbers, so I can't work.
You have headache on one part of your head, but and what about the blurring? Is it in both eyes?
Yeah, it is in both eyes, doctor.
Both eyes. Okay. Did you had any clot, any history of clot before?
History of blood clot? No, doctor.
Yeah. Any
No,
family history of blood clot?
no, doctor.
Any family history of note or any
No.
similar condition?
Only my
Okay.
mother had migraine as well.
Okay. Right. So, do you smoke?
No, doctor.
Okay. And how many units of alcohol do you take in a week?
I'm not drinking.
Okay. So, let's ask you a personal question. Are you married?
Yes, doctor. I'm married.
Okay. And you are you taking OCPs?
No, doctor. I'm just using
What
it
about your
regularly.
menstrual cycle?
It is
Is
regular.
it regular?
Yeah.
Okay. And did you have any pregnancy loss?
No, doctor.
Okay. Any recent travel anywhere?
No.
Any contact with sick patient or any ill patient?
No, doctor.
Okay. And do you recall that you have been taken you've taken your shots before?
Shots? I'm taking all my
Yeah.
shots. I took all my
Okay,
shots.
right. Okay. So what about your mood?
It's bad with this pain for sure.
And what about your sleep? I mean, how do you sleep nowadays?
I'm not sleeping well because of this headache.
Okay. Uh, but right. So let me ask a few more questions. It may or may not be related, but it might help us understand the condition more. Do you have any lightheadedness?
You know what?
Any fits?
It's no, doctor.
Okay. Any disturbance in hearing? Hearing impairment?
No, doctor.
Okay. Any chest pain?
Chest pain, no, doctor.
Any breathlessness?
No.
Okay. So you said earlier that your water work is fine, but did you ever notice that early in the morning it changes color, it gets dark?
No, doctor.
Okay. And is there lumps and bumps in your body?
No, doctor.
Okay. You're saying something that this things comes and goes, right? Or is it persistent?
What is this? The headache?
The headache and the blurring of the visions?
No, it is almost persistent in the last 10 days.
Okay, right. And do you have any tummy swelling or tummy mass?
No, doctor.
Okay. Any disturbance in swallowing food?
Any what?
Disturbance in swallowing food?
No, doctor. 2 minutes
Any
remain.
gland? Okay. So, as I've talked to you till now, the information I gathered from you is that you have you had a known history of migraine for the last 15 years, but recently for the past 10 days, you're experiencing a different kind of pain, and which is more marked on one side of your head and is associated with disturbance in your vision as well as occasionally double vision. You also had recently had high fever and also some sinusitis, and you do have some generalized body ache and swelling. Uh, well, uh, all the symptoms, the headache and the disturbance in vision, I think this is from a condition called cavernous sinus thrombosis. This is a disease where one of the blood channels there's some dilatation of blood channels in your head. When one of those get clogged up, it leads to this disturbance in your vision as well as double vision, and may also can cause severe headache. It is a serious condition, so we will need to admit you. We'll need to run some tests to confirm the test, and we will also have to start you on some blood thinners once it's diagnosed. And in the meantime, we will definitely refer you to we will take opinions from the nurse specialist to help with your disease. So, do you have any concern?
Yes, doctor. I want to know what's going on. Is it a serious condition, doctor?
Yes, I'm afraid it's a serious condition because as you're already having some disturbance in vision, which means the nerve in the back of your eyes are getting compressed. So that is something we need to worry about. However, it's treatable.
Okay.
Is there something else you'd like to ask?
But doctor, please prescribe for me some medications because I want to go home. I'm not able to be admitted, doctor.
Is there any particular reason you have to go home?
Yes, because my kids are alone, so I can't leave them there.
But you need to understand that the condition you're suffering is a very serious one, and it has to be treated after you get admitted. And if you don't get treated, you may even lose your vision. So, do you think you can call some of your relatives to come over at your place to look after your kids in the meantime?
What?
Any of your relatives who can help you looking after your kids?
Yes.
Okay, so we can call them for you.
Yes.
But it's really important for you to get admitted at this point.
So I will be admitted, doctor.
Yes.
Okay. Okay, doctor, thank you. Thank you, doctor. Time finished. Okay, doctor, there is 1 minute to collect your thoughts. This is in the real exam. There will be 1 minute. Then the examiner questions will start. So, doctor, what's your differential diagnosis for this patient?
Patient had a background history of migraine for the past 15 years and recently worsened with some neurological impairment. So my first differential, this is a case of venous sinus thrombosis. However, with high spikes of temperature and sinusitis, cerebral abscess also a possibility. And well, as she's overusing her medication, so medication overuse headache can also come as a differential. Although this won't cause the neurological disturbance in a patient.
Overuse of medications. Do you think overusing the medications can cause the headache that increase by leaning forward and coughing and sneezing?
No, the character of the headache is certainly against it, and also the neurological disturbance she's experiencing doesn't support the diagnosis of medication overuse headache.
Okay, so what are you going to do for this patient, doctor?
First, we need to do a CT scan, and but to diagnose venous sinus thrombosis, which is a fast differential, we will need to do an MRA, and also some routine investigations like CBC, inflammatory markers, renal function test, liver function test, and we need to look for the cause of venous sinus thrombosis. It can either be an infection or it can be because of thrombophilic hypercoagulable state. So we need to rule out, to check for any hypercoagulable state, we need to look for any potency, proteinase.
What is the imaging modality you are going to request?
First an MRA and then followed by an MRI, followed by an MRA.
MRA.
Yeah. MRA is diagnostic for venous sinus thrombosis.
Okay. So do you need MRV?
Sorry, it's MRV.
MRV, okay. So doctor, how do you explain the presence of this double vision and the pain on moving the eyes?
Double vision is as the third, fourth, and sixth nerve passes through the venous sinus. So impairment of this, it can lead to double vision. It can lead to ophthalmoplegia. However, pain on eye movement is something which can be caused by optic neuritis. We're not so sure how this can be explained here.
So you think affection of cranial nerves causing that?
Yes, third, fourth, and sixth.
Yes, great. Okay, doctor. How would you treat the patient?
That will depend on the cause. Initially, analgesics to help with the symptoms. And if the venous sinus thrombosis is due to infection, then antibiotics and fluid. If it is due to any hypercoagulable state, then definitely anticoagulant, heparin followed by warfarin.
Does it make any importance to you to know if this patient take any medication when she was diagnosed with sinusitis?
Oh, yeah, I'm sorry, I didn't ask about that. Yeah.
Yeah. Okay.
But I asked for a medication list, so do I need to ask again? I mean.
Yeah, if you ask the patient, she will tell you that she was prescribed an antibiotics she used for 1 day, and she had some gastric upset and some loose motions, and so that she decided not to continue the medications. She didn't complete the medication; she stopped it by herself. That's why you can't see it in her medication list. Okay.
Medication list is something which the patient prepares?
Is what?
I mean, the list the patient brings, is it something the patient writes down?
Yeah,
or is it a prescription?
Yeah, the patient is taking the Enral and Relback, the things that she is taking regularly, but she was prescribed a medicine and she's not using, so she don't care to bring her prescription because she's not a doctor and she don't know the relation between her infection with the recent headache. She's thinking that it is more uncontrolled migraine. Okay. Okay, doctor. So thank you very much. Thank you, Dr. Rita. Okay, doctor. So now we will start discussing this case. Thank you, Dr. Rita. You did very, very well. You will definitely get the full mark if this was your performance in the real exam. yes, this case is cavernous sinus thrombosis. And the cavernous sinus thrombosis is a condition at which it's presented in 95% of patients with a headache. And this headache will have the criteria of increased intracranial pressure. And they will show you in the coming slides how to exclude the cases, how to ask about the cases or the causes of the headache that can cause increased intracranial pressure. What I like in your performance that you're organized, I would like to make it a little bit more organized for any headache case, and they will show you in the algorithm how to exclude all the known causes of headache, whether the headache with increased intracranial pressure or other causes of the headache. Okay, this will be in the slides of the headache that usually we are using. We remember in the exam, we have Dr. Amir, who was with us in the previous course, and his case in history was headache as well. And he just, he told me that he just memorized, he remembered the algorithm outside, then he went inside and he asked all the question, and he was confident that he didn't miss anything because he just remembered this page. You know, my system, I don't like to have only differential diagnosis. I like to have an approach to ask everything, so you will be very confident while asking. We don't believe in the system review as just a part of the history. They don't like anymore. You need the system review and the things related to the case itself. If some questions, and I like when you ask it about the urine, because patients with buffness of eyes, you need to know if there's something in the urine. Okay, if there is a high blood pressure, so you need to ask more about the neurological symptoms, about mental disturbance, about any disturbance of consciousness, okay, any disturbance in concentration and this stuff. So, but you did well. I can't find anything. I like when you ask it about the impact of the symptoms on your life, because this have its mark. And as we said before, in the first day of our course, we discussed with you the mark sheet of the examiner. So you need to know what are the things that they are looking for, so you will not lose marks. Sometimes you think you did very well, but the problem that you forget to ask about the things that you will lose marks if you didn't ask about. I like when you summarize, because summarization is very important in the history as well. Okay. Yes. So thank you, Dr. Rita. You'll get a full mark, clear full mark in this case. Thank you very much. You are very confident in your performance, very organized, and I like your self-confidence. Okay. And I asked every doctor to have this self-confidence while asking. Again, remember, my advice to all the candidates, the PACES exam is like an interview. I don't want you to think like it is an exam. It's like a normal daily case. You see 7 cases in your every day in your work. So this is 7 cases. You are going to show your supervisor that you do well with these cases. So this is what I want you to do. It's interview. So show your best. It is not an examiner. It is not an examination and examiner. It's an interview, and you want to show in the interview that you are a very competent doctor. If you think that way, you will be acting totally different than when you looks very afraid or very worried as a candidate. You are a doctor, and this is an interview, and you want to show them that you are doing that every day. Okay. So now I will just show you about this case. Just this was the details of the case. The patient has migraine since 15 years, and she is on prophylaxis. The new headache is totally different than the previous one. And there is a symptoms of increased intracranial pressure since 10 days. The headache is retroorbital or frontal area with occasional radiation to the occipital region. Then after that, she starts to find there is a dropping of the eyelids, and there is pain with eye movement and double vision. If asked, and Dr. Rita asked that, there is a recent fever diagnosed as severe sinusitis since 15 days, and it was prescribed antibiotics, but didn't take it as it caused severe abdominal upset and lost motion. Okay, this was our case. Okay, and I just want to give you a hint. Usually this is our approach. We just go to discuss the case, then we discuss the general algorithm of the headache. For the cavernous sinus thrombosis, you need to know that recent infections, okay, or the causes, recent infection and manipulations. So you need to ask about any recent surgeries and recent trauma, some dental procedures, oral procedures, ear procedures, and ear infections as well, dental infections. All these, not only the sinuses, can cause cavernous sinus thrombosis. Okay. Then you need to ask about the timing of the onset. because for the cavernous sinus thrombosis and even any venous sinus thrombosis, there could be aseptic. There's septic, okay, and aseptic, which is called acute and subacute. The subacute looks more benign, not benign. It looks like it is not that severe, not very acute. It comes gradual, okay, and it will not be associated with fever. Sometimes the fever develops after the thrombosis, but usually for the septic cavernous thrombosis, there will be a high fever. Okay, so the majority of patients, there is septic cavernous sinus thrombosis. It's variable, and majority of patients present with acute toxic state. Sometime, and less commonly, the presentation will be indolent. Okay, and as I said, it's usually you need to ask about any dental ear infection, okay, and exclude trauma or any recent procedures as well. So I want you to remember to ask this question. Then you need to ask about the progression of symptoms. Usually there is a headache, and the headache present in 50 to 95 cases. This is the primary presentation of cavernous sinus thrombosis, and I will tell you exactly how to ask about that and how to be very sure that these are symptoms of increased intracranial pressure, okay? And then it will be preceded by ocular manifestation. This headache usually starts as unilateral, and sometimes it becomes bilateral after that. The area that affecting, when I told you that it is behind my eye and in the frontal area, and sometimes going to the radiated to the occipital area, this is because it is affected the ophthalmic and maxillary branches of cranial nerve 5. Okay, that's why these symptoms happen. As well, the fever is very important. The eye symptoms, that may be edema, there may be ptosis, there may be ophthalmoplegia, and there may be as well double vision. And lastly, if this patient still untreated, you may find mental status change, and you may find also neurological symptom. This patient may have weakness, may have slurring of speech, may have a weakness anywhere, numbness. So any neurological symptoms can happen with this increased intracranial pressure, and any cranial nerve affection can happen. So this is a very important topic, and it came in the exam many times recently. Not the cavernous sinus itself, only any venous sinus thrombosis and any cause of increased intracranial pressure. They like to bring the prolactinoma as cause of increased intracranial pressure and headache. They like to bring pseudotumor cerebri or the spontaneous the tumors, the primary tumors in the brain as well, came recently in the last diet. So this slide, you will see in this slide as well the eye affection and the symptoms of the eye. I don't want you to know that in details, but I want you to link the things together. When you found ptosis, when you found chemosis, when you found proptosis, when you find there is a loss of corneal reflexes. Okay, actually this will be in station 5 if you find something like that because of affection of cranial nerve 5. There could be ophthalmoplegia, complete ophthalmoplegia because of dysfunction of cranial nerve 3 and 4 and 6 as well. Okay, and there is for sure affection and decrease in visual acuity and blindness. Okay, so this was our case of today, and how to treat this patient, how to investigate her. We'll do the MRV. You can mention the CT if you want, and you need to mention MRV. And then you need to go to do some blood works like CBC and blood cultures. Okay, and you need sometimes to do lumbar puncture, and you need to do also a hypercoagulable status study. You need to check the factor V lining. You need to check the antithrombin 3, protein C, protein S. You need to do hemoglobin electrophoresis for sickle cell diseases. Okay, you need to do the blood works for the antiphospholipid syndrome, the anticardiolipine antibodies as well. Okay, how to treat this patient? You need urgent admission. This is very important. And as I advised before, this is clear case of admission. But for every doctor who become confused when you are asked about will you admit the patient or not, if you are in doubt, admit the patient. If you are not sure, admit the patient, because it's not a big deal if you admit the patient when he don't need or she don't need admission. But it is a very big deal if you didn't admit a patient and send him home and he or she has a serious condition. So again, this is the rule. If you are confused to admit the patient or not, please decide to admit him, because this is more safe. If you decided to send him home, the examiner will write that you are unsafe doctor. You send a serious case home. So if confused, choose admission, okay? Now we are done with our case. We will go to discuss the headache. And this is very important. I want every one of you to have a paper. We will send you this page on the WhatsApp group or in the Facebook group. Okay, the Dr. Mahmoud and Dr. Ahmed, our admins, will send to you so you can print this page. So we will discuss now our approach for any headache case. Okay, this is the headache for the PACES doctor. When we start with the headache, you need to ask the patient to describe the pain. Okay, Dr. Rita, I will please close your mic.
Yeah.
Okay, thank you very much. We will ask to describe the pain, and you will ask the Socrates, as we said, all the books. This is the mnemonics used in all the books for any pain. You need to ask about the severity and the site of the pain. This is for the S's. And for the O, you need to ask about the onset of the pain. And you need to ask about the course. The onset is acute or gradual. And the course, is it progressive or is it improving? Okay, and the R for the radiation, and the A for alleviating and aggravating symptoms, and the T for the timing, okay, and the S for the size, as I said. And you need to ask early about visual problem. You will find in every algorithm I'm sharing with you the yellow questions. What I call the yellow questions is the question that you need to ask specifically for this case. So visual problem should be asked very early in the headache case, okay? For the doctors who are attending the course with us and didn't attend the exam yet, we make some changes in this page, in this algorithm, and they will send to you in the private group of the course. Okay, because here you need to start asking about the two types of the headache. There is a serious causes of the headache, and there is a common types of the headache. For the serious type of the headache, I want you to ask these two boxes together. Before we was asking about the purple, and then we ask about the blue. I want you to ask both together. And if you remember, we said the MNLBS, okay, which we call it in Arabic manilbis or milabis, if you want to call it like that, okay? So the M for the morning, the headache in the morning, the N for the nausea, the L for leaning forward, the B for the blurring of vision, and the S for the sneezing and coughing, okay? So we call it manilbis, or you can call it mulabbis if you want to remember this question. So you need to ask, and you will find it is increasing in the morning, associated with nausea, increase with leaning forward, associating with blurring of vision, and it increase with sneezing or coughing. And it may be associated with neurological symptoms like fits and weakness. And I like when Dr. Rita asked all these questions. At the same time, I want you to ask for the fever, okay, because fever and increased intracranial pressure, we need to exclude the meningitis and the encephalitis and something like septic venous sinus thrombosis, okay? So here, once I found the answers for the purple box, yes, so we are going to the causes of increased intracranial pressure. And when we have the fever, I will start thinking about meningitis and encephalitis and septic thrombosis as well. So I need to ask about any previous infection. Again, doctor, forget about asking bizarre questions from right and left. I want you to memorize this page. When you study it, when you have it printed in your file, you will just read it in the night of the exam, okay? So, or you will practice it with your friends and they will tell you how to practice it. Then you will be very confident with any headache case and you will not miss anything, inshallah, okay? So once I found the symptoms of increased intracranial pressure, like morning headache, nausea, leaning forward, increased blurring of vision, and any neurological symptoms, I would start to think about these, the HPTV. The HP, you know, this brand of computers, and the TV, which is a TV. Okay, so for the H, I'm asking about the hemorrhage. And as I said before, usually in my lecture, I'm telling you I have a fixed questions. When I'm asking about hemorrhage, there's 4 questions for the hemorrhage. Any history of bleeding, any family history of bleeding, any bleeding, if there is, yes, any bleeding from any other orifices. Okay, then I will ask about any blood thinning medication. Here I'm asking if the patient in blood thinning, so the patient may have intracerebral bleeding. Okay, I'm asking about any history, family history of bleeding because of any condition like hemophilia, any bleeding condition. Okay, I will ask about any history of reverse bleeding, hereditary hemorrhagic telangiectasia, any causes of other bleedings. Okay, any bleeding from any other orifices, so I know that the patient have generalized cause affecting multiple system and causing bleeding, epistaxis and bleeding in the knee joints. There is gum bleeding. Okay, there is subconjunctival bleeding. So all these questions are important. So 4 questions. Any personal history, please write it down if you didn't write it with me before. This is the 4th question for the bleeding. As I said before, I have 6 questions for the clotting, 4 questions of the bleeding. Any personal history of bleeding, any bleeding of any other orifices, if there is one bleeding, any family history of bleeding, any blood thinning medications. Okay, the subarachnoid hemorrhage. It is, the patient will describe it as the most severe headache in my life. Okay, I want you to ask as well about any family history of kidney problem. I want you to ask about the kidney problem, and Dr. Rita did that. Any change in the amount of the urine, any flank pain. Okay, this is because, again, in the MRCP, they like the association between the rupture cerebral aneurysm, which is associated with the adult polycystic kidney disease. So you need to ask this question, and when you are familiar and when you know this algorithm by heart, you will ask this question and the examiner will be very impressed. So you will ask about the severity, you will ask the 4th question of the hemorrhage, and you will ask as well about the adult polycystic kidney disease by asking about change in the color and amount of the urine, and you will ask about lower leg swelling and ask about the family history of kidney problems. Okay, then the P, this P is for pseudotumor cerebri, for the pseudotumor cerebri, okay, which is which we call idiopathic intracerebral hypertension. And actually there is confusion that some candidates know that when you call it idiopathic, so you couldn't find a cause. So when you found the cause for increased intracranial pressure like medications, so it is not idiopathic anymore. Okay, so it will be called, in this stage, it will called secondary intracranial hypertension. Okay, so what are the 6 questions you need to ask about the pseudotumor cerebri? What are the 6 questions? Go ahead and write that into the chat box, please. Dr. Sana, we will repeat this Socrates if you want, and please, Dr. Ahmed, answer Dr. Sana for what Socrates refers to. I need the doctors, please, to write what are the questions you need to ask about the pseudotumor cerebri, or go ahead and share. I just want you to share in the lecture. Any change in weight? Okay, so Dr. Ahmed said any change in weight. What else? What else, doctors, you need to ask? Drugs. Okay, Dr. Muhammad Ali, please call it medications, not drugs. When you want to ask about medications, call it medication, not drugs. Dr. Amani, you will not ask here you are female or not. She is already female. So oral contraceptive pills, steroids, I agree. Okay, pregnancy, cycles. Okay, so let's make it more, yeah, acne. I like Dr. Jaya asking about acne medication. Yes, let's make it more simple. Again, I want to tell you that in PACES, you don't need to know every, yeah, pregnancy, right answer, Dr. Amani. Okay, for the 6th question, I don't want you to know 100 things. I just want you to know 6 things, 5 things that you can ask and catch the common things. Okay, for the 6th question, please go and write it. There is 4 things related to weight gain. The first thing, recent weight gain. Recent weight gain caused increased intracranial pressure. Pregnancy is the second thing related to the weight. Then steroids increasing weight. Then oral contraceptive pills increase the weight. So 4 things related to the weight: increasing the weight, pregnancy, steroids, and oral contraceptive pills. Then 2 things related to medications. The acne medications. They found that the patients treated for acne, they start to complain the symptoms of increased intracranial pressure. And when they studied that long time ago, they found that the doctors of the dermatologists, they like to prescribe the tetracycline or the doxycycline group for the treatment of the acne because it is effective. And at the same time, one of the most effective medications for the acne is the tretinoin, which is called retin A, which is vitamin A. and the association of using the tretinoin with the tetracycline, both of them causing what's called the increased intracranial pressure. And here we don't call it idiopathic anymore. It's called secondary increased intracranial pressure because it's not idiopathic. It starts to be there is a cause already, it becomes secondary. How to diagnose that? We do a lumbar puncture, and the lumbar puncture here will be diagnostic and treating because you will decrease the tension of and you will stop the medication causing the condition, whatever, what is it, will advise the patient to lose weight, stop oral contraceptive pills, or whatever. So I just want you to memorize these 6 questions for the pseudotumor. The P referred to the pseudotumor. Just write it down, please, doctor. 4 things for the weight. It's weight. Again, it's a game. I want you to remember the things. I know that there is some doctor will give me 100 codes for pseudotumor, and I totally respect that. But actually, in the PACEs, you don't need to ask 100 questions. You need to ask, they use a common things. So I want you to ask these questions, okay? 4 questions, weight gain, pregnancy, okay, steroids, and oral contraceptive pills, and ask about any acne treatment, including antibiotic or including what's called vitamin A or vitamin A or tretinoin, okay? So this is for the P. What about the T? The T refers to tumors. Okay, here I'm talking about tumors. Okay, and for the doctors who attended with me the lecture before, we have something we use instead of the system review, what's called the bundles. We have something we discussed in the first day in the course, which is the bundles. It is the questions that you will use to answer any case that you can't catch the diagnosis. I mean, we have bundle 1, bundle 2, 3, 4, 5. And when we ask this bundle, we are covering all the common diseases, all the common symptoms that can be hidden. Sometimes it's just a fever, case of fever. So you need to ask a question to catch what is the cause of the fever. Then you will go to the bundles. One of these bundles is bundle 1, and bundle 1 is related to the diagnosis of tumors and diagnosis of TB, okay? And for the tumor, I'm asking about weight loss and about high temperature, asking about loss of appetite, asking about lumps and bumps, coughing out of blood, exposure to chesty sick patient. Okay, so these bundles, if you look for my previous slides, you will find the bundles, and we ask these bundles. You will see here that bundle 1 written, which means I'm asking about the tumors and the TB. Here the T referred to tumor. Okay, then the other tumors that I care about is the pituitary tumors, and here I need you only to ask screening question, and this is common, and it came in the exam. It came in Oman in every day. They bring a case with headache with pituitary tumor. Okay, how to ask about pituitary tumor? You will ask about the acromegaly. You will ask about change in the size of the ring and choose, and change in the facial features. Okay, then you just screening question. You don't need to ask 10 questions for the acromegaly. Then prolactinoma, I will ask for the male about any change of the size of the breast. Okay, any the blurring of vision, for sure, the symptoms you asked already about the intracranial pressure, okay, and you will ask about the desire. You will ask about loss of interest in having the intimate relations, and you have erectile dysfunction. So any problem with your intimate relation regarding the ability he's able to sustain erection and the desire itself. Is he still interested in having intimate relation? Okay, for the female, there will be a regulation of the menstruation, or we call it the period in the exam. So you'll say is your period is regular? Okay, do you notice any secretion coming out from your nipples? Okay, or from your breast? Okay, so just a screening question. Beside the headache, you will ask any change of the size of your ring, any change the size of your shoes, okay, any change of the size of your breast. Sir, can I ask you some private question? Do you have problem in your intimate relation regarding your desire? Do you still interested in having the intimate relation? Is there any problem of sustaining erection? Okay, then for the females, you can ask about, again, the libido is affected, and again, the period is regular or not, and the third thing about the secretions coming from the breast. And if it's prolactinoma, you will get some yes answers. And in this case, you will go ahead and continue as prolactinoma, okay? Then we need to ask about secondary tumors that can send mets to the brain. And usually, as I said, whenever I say secondary tumors, I mean the main common tumors, the lung, breast, and prostate. For the lung, I'm asking about the coughing out of blood. Okay, I already asked about the general symptoms of cancer, then I will ask specifically about the lung. I will ask about coughing out of blood, shortness of breath. For the breast, I will ask about lumps and bumps in the breast. And for the prostate, I will ask about stream problem, any change in the urine amount, blood coming with your urine, okay? And then you can add to them colon cancer if you want to. You will ask about any blood, and you asked it in bundle 1, any blood coming from your back passage, okay? So these are, sorry, I will close the mics. Dr. Manal, your mic is open. So these are how to ask about the T. Then for the V, I'm asking about venous sinus thrombosis. And here I ask 6 questions. This 6 clotting question, I want you to write it down if you didn't write it before. Ask about any personal history of blood clot. Why I'm telling you to type that? Because we will use it in all the cases. Whenever I want to ask about blood clotting, I want to be ready to ask these 6 questions very fast. Do you have any past history of or personal history of blood clots? Do you have any family history of blood clots? Okay. Do you have any heart problem? Any problem in your heart rhythm? This is for the AF. Any history of smoking? History of recreational drugs? Okay. Then the 4th question, I'm asking about any history of any oral sores, any mouth sores, any sores in private areas. Close the mic again. Okay, any history of mouth sores, any history of sores in private area, any joint pain. This is for basic disease. Any change of the color of the urine at the early morning. This question is very important, and this case came many times. You will just go through the headache, go down here, here, then you will catch it here in this stage. You may find that this patient have paroxysmal nocturnal hemoglobinuria. So your question will be about changing the color of the urine at the morning. Then the question about the joint pain, about the rash in area exposed to the sun, about recurrent fetal loss, okay, about the change in the urine, frothy urine, amount of urine. Here I'm asking about the antiphospholipid syndrome. Okay, so the 6th question, personal history of blood clot, family history of blood clot, okay, heart problem and drugs and oral and smoking and oral contraceptive pills. Then the last 3 questions about basic disease, about the paroxysmal nocturnal hemoglobinuria, and about the antiphospholipid syndrome. Now you will feel that I'm asking too much questions, and doctor, we don't have time to ask this question, and this is not true. If I repeat that for you, it will take less than 1.5 minutes to go through all these questions, okay? Because once you catch something, you will proceed. And here, when Dr. Rita asked this question, she found she will play on the left side of the algorithm. So she found she's working here. She asked about the fever. There is fever. So she started to link increased intracranial pressure with the fever, with the history of sepsis. So, and there is a history of sinusitis. She asked about infection. There is sinusitis. So she jumped here to found venous sinus thrombosis. Okay? Sometime you will find no fever, you will proceed down, you will ask about the hemorrhage, nothing, ask about the risk of pseudotumor, nothing. Then I went here and I catch it, it is prolactinoma. I went here, all these are negative. Then when I asked the 6th question, I found it's positive. So I will consider the diagnosis of venous sinus thrombosis as a cause of headache. Okay, then the 3rd cause of a serious causes of the headache, I will ask this question about any jaw and scalp pain and jaw claudication, shoulder stiffness, and visual problem. And this question is very important for the joint cell arthritis or temporal arthritis. So because there is overlapping between it and the polymyalgia rheumatica. So because the polymyalgia rheumatica and joint cell arthritis, both of them are merging, so you need to ask about any pain while dressing your hair, any jaw claudication while showing, any shoulder stiffness, any visual problem. So this will be your first 3 questions. And when you find they are negative, no need to proceed in this side. I mean, when you found that it is not the symptom of increased intracranial pressure, and it is not joint cell arthritis, and there is no fever, no neck stiffness, no rash, Okay, no exposure to infected. Sometimes it's a teacher exposed to sick patients, sick children. So, and she's immunocompromised for any reason, for pregnancy, for diabetes, and she catches meningitis. Okay, so this is the left serious side of the headache cause. Give me the okay on the chat box that you are okay with this side, because we will go to the other side, which is very important as well. Give me the okay in the chat box that you are okay with the left side of our headache page. Give me the okay. Okay. Okay, great. Dr. Magid, Dr. Ahmad, Dr. Amani, you are all okay. That's great. Now we will go to the other side. We asked about the serious causes of the headache, and we found that nothing there, and I want to go back to the other causes and the common causes that can come in the exam and can cause the headache, and I want to catch it as well. So the first thing is of the common headache is the migraine, and then the cluster headache, and then the tension headache. And again, I want to remind you, if you ask these three questions and the answers are no, so we are done in the first 30 seconds, then we will go to this side. So then you need to go through all the algorithm, okay? For the migraine, there is criteria you need to ask about. Is it unilateral or bilateral? Is there a family history of this headache? Okay, is it preceded by some symptoms like eye flashes, which is called the aura? Okay, is it associated with feeling of sickness or throwing up, nausea and vomiting? Is it associated with fear of lights and sounds, so you prefer to be in quiet room with quiet light? This is for the photophobia and the phonophobia. Is it related to your time of the period? Is it related to lack of sleep? Is it related to alcohol and caffeine? So this question, we call this question the aggravating factors. Okay, then you will ask about the oral contraceptive pills, the usage of oral contraceptive pills. So again, what I want to ask about migraine, I want to ask about, is it unilateral or bilateral? And remember, doctor, the migraine is not only unilateral, sometimes it is bilateral. So never exclude the migraine because it is unilateral, it is bilateral. It can be migraine and can be unilateral, bilateral in more than 35% of the cases. So unilateral, bilateral, family history of the same condition, preceded by aura, associated with nausea and vomiting, photophobia and phonophobia, okay, related to period, oral contraceptive pills, caffeine, alcohol, cheese, sometimes wine, the cheddar cheese affecting increasing the migraine, and related to the lack of sleep. Okay, this is for migraine. For the cluster headaches, you need to ask about, is it around the eye? There will be pain around the eye with watering of the eye. This is the first question of the 4 questions. Then the blocked nose and runny nose. So the eye will be the pain around the eye with watering, then blocked nose and runny nose. Then there is several times in the day, same time in the year. So it will be affecting several times the day, and same time it will be, let's say, in the beginning of the summer every year, and affecting every time, many times in the day. So this is the criteria to ask about class. Does it affect your eye? Do you feel that the pain around your eye? Did you notice watering of your eye? Any blockage of your nose associated with this headache? Okay, any runny nose? Okay, then does it coming many times at the day? Okay, is it at the same time of the year? So this cluster headache, and the importance of the cluster headache, we give them the same prophylaxis as the migraine, but we treat them with the oxygen, with 100% oxygen. Okay, then the tension headache, and the tension headache is very common to come as the hidden headache in the case. So you'll find usually they bring in the case 2 types of headache, old one and new one. And I like when Dr. Rita discussed that. She checked the first one, and she found that the first one is the headache for the migraine, and there is a new headache with a new character. That is when you ask, usually they put the tension headache because everyone in the life have a tension headache. To ask about the tension headache, you will find that it is band-like, usually in the end of the day, and associated with stress and depression. So 6 question, 4 question, 3 question. Okay, so write it down because this is, you should write it. It is not written in the slide. These are the question of the migraine, the question of the cluster headache, and then the questions of the tension headache. Okay, then I will go to shukran. And what is shukran? Remember it as shukran. Shukran. This is the mnemonic I'm using. Shukran for the non-Arabic speaking mean thank you or thanks. Okay. So shukran to remember. Again, you remember me when you are in the PACES exam, when you are outside in station 5 or in the history, and you just remember this page. And when you are inside, you will ask this question. If you practice this page very well, you will ask that there, and you'll be very confident that you didn't miss most of the common things that can come in the exam. I want you to write down what these refer to. Okay, the first S is referring to sinusitis. So sinusitis not all the time will cause a cavernous sinus thrombosis. Sometimes it is just a headache due to sinusitis. So the patient will have a pain in the face, will have a problem, non-blocked nose, will have this headache coming in his forehead, and he may have a diagnosis of sinusitis before. So the S refer to sinusitis and refer to SLE, the systemic lupus. Systemic lupus causes vasculitis, and it's a common cause of headache as well. Not common cause of headache, I mean all the patients with systemic lupus will complain of headache and neurological symptoms. Sometimes they have fits. Sometimes the only neurological symptom is the blurring of vision and the headache. So I want you to ask about rash in area exposed to the sun, joints pain, frothy urine. Just 3 screening questions. Mouth sores as well. Okay, so I need you to ask screening question. Then the H will refer to hypertension or hypotension. You will ask about any known high blood pressure. Okay, you will ask about hypotension. Do you feel dizziness? Did you check that your blood pressure is low? Do you feel weak? Did you lose your consciousness? Do you faint? So you ask about hypertension and hypotension. Do you look more pale than usual, as anemia and hypotension causing hypotension? Okay. The patient will have hypotension as well, will have the two. There is a problem in intimate relations. Hello, sorry, I just lost my connection. Hello, you hear me now? You hear me now? Okay. So for the obstructive sleep apnea, I said there is, you stop at H. Okay. So for the H, there is hypertension and hypotension. Hypertension and hypotension. So you need to ask if he was diagnosed before by high blood pressure or low blood pressure. Okay. You need to ask about the Addison because of the association. If you faint, if you look more pale than usual, sometimes it is anemia causing the headache. Okay, so, and you will know the algorithm and mnemonic of anemia. We have a specific mnemonic and specific algorithm and lecture for anemia. For the O, obstructive sleep apnea, and as I told you before, there is 4 questions to ask about obstructive sleep apnea. Again, doctor, I want you to put 100 circle about obstructive sleep apnea. You need to know what to ask on obstructive sleep apnea, what to examine, what to investigate, how to treat. Obstructive sleep apnea is a very common case in the PACES. If you lose 1 mark, it is not accepted to lose 1 mark in obstructive sleep apnea in the exam. Okay? For the obstructive sleep apnea, 4 questions. You will ask one question in the morning, one question during the day, one question before sleeping, one question during sleeping. The first question in the morning, that there is a morning headache and feeling of unfreshness. The question during the day, do you feel sleepy? Any history of sleeping during driving or during watching TV? This is during the day. Just before sleep, the intimate relation. Sorry, sir, can I ask you a question? Do you have any problem in your intimate relation? Okay. Then during sleeping, okay, snoring and gasping for air, or witness to gasp for air. Okay, so remember it by the daytime. Morning, during the day, just before sleep, and during sleeping. These are the questions of obstructive sleep apnea. What to examine on obstructive sleep apnea? We will discuss this in the lecture of obstructive sleep apnea. How to investigate and how to treat, very important, and we will discuss in the obstructive sleep apnea. Okay. Then what the C referred to, very important, refer to CO poisoning. CO poisoning. I have a very common case. Fuel burning devices at home. When you have a new home, when you have a new job, when you have a new device at home. Sorry, connection problem again. Hello, do you hear me? Okay, if I have the connection problem because it's raining outside here, so the C for CO poisoning. So CO poisoning, CO poisoning, you need to ask about any new home, any new job, any other person at home affected by the same symptoms, any new fuel burning devices at home. They may have a new oven, they may have a new heater. So you need to ask these questions. So question for CO, you need to ask about new job, new home, new fuel burning device, new heaters. Okay, very important. Other members at home complaining the same symptoms. What about the R? The R referred to refractory errors. Sometimes it's just a vision problem. Our doctor who attended the exam recently, he told me I didn't find anything specific, and this is right. Sometimes it's just a tension headache, and the case is to see how to exclude the other causes of headache, and this is known in the PACEs. Sometimes it's just about the approach. It's just about not catch a diagnosis. They want to see how you ask about the headache. Okay, so for the R, it's referred to refraction error. Do you have a problem with your vision? Do you wear eyeglasses? Maybe you'll say, I don't like to wear it. I was prescribed one. Okay, so refractory error. What about the A? The A refers to two things, doctors. Anemia and analgesic induced. For anemia, you need to attend the lecture of anemia because anemia is a big topic and there is a mnemonic for anemia, okay? And the other A is for analgesic induced headache. For analgesic induced headache, it is just asking about what medication taking. If you know, if you take medication for 12 days, it is the cut of 12 days, a lot of analgesics, you may consider it an analgesic induced. But remember, you don't just catch it and say it is analgesic induced. Okay, like Dr. Rita said, it could be analgesic induced. And every patient who have headache, you will find yourself, you use analgesics more than 12 days when you have headache. I used personally for 2 months. Okay, but I have migraine actually. It's not for analgesic induced. So consider it a diagnosis by exclusion. After excluding everything, consider the analgesic induced headache, okay? And the last N refer to neuralgia, trigeminal neuralgia. And in this case, the patient have a severe facial pain with showing as well. And it will not be the same as the temporal arteritis. And it is important to ask about that because it's treated by carbamazepine, which is the Tegretol. It have a specific way of treatment. Not very important, but it's important by the way to ask about. So now let me show you, I know it looks like a big issue now, but let's see if I am Tan going to a case and it's headache. I would ask the patient to describe the pain, ask him about the severity, that it's acute or it's coming acute or gradual, increasing, decreasing, what increase it, what decrease it, where does it radiate, Okay, it is at the morning, at the night, what improve it, what aggravate it, and then any visual problem. Then I will go to the purple line and I will go and ask about the manilbus. Does it increase in the morning associated with feeling of sickness, increase with leaning forward, any blurring of vision, increasing with sneezing and cough, any weakness, any numbness, any history of fits, yes or no, any associated with any fever. Okay, the N for neuralgia, trigeminal neuralgia, doctor asking me about the N. Then any jaw pain, any pain while combing your hair, any scalp pain, okay? Any shoulder stiffness, visual problem. If I found increased intracranial pressure, I will ask the 4 question of the hemorrhage, and I will ask about the history of kidney problem and family history of kidney problem, and will ask whether any trauma of the head because of subarachnoid hemorrhage. You need to ask about trauma, and you need to ask about the severity will guide me for the subarachnoid hemorrhage. Then the pseudotumor, I will ask the 6th question of the pseudotumor, 4 for increasing weight and 4 for the 2 for medication. Then I'll ask about the primary tumors and the secondary tumors. Then I will ask about the venous sinus thrombosis by the 6th clotting question. If all these were negative from the top, I will just stop here and I will go to the migraine, asking 6 questions, clusters 4 questions, tension headache 3 questions. Then I will remember shukran, I will write it outside, not to forget anything. Then ask about sinusitis and SLE, hypertension, hypotension, obstructive sleep apnea, 4 questions. CO poisoning and refraction and anemia, and the analgesic induced and neuralgia, trigeminal neuralgia. Then I will ask about the impact on that in the life. Then I will ask about the job. Then I will ask about the marital status, about the surgical history, about the travel history. This you can ask in 1 minute, because again, never jump to ask about smoking and about alcohol and you didn't catch the diagnosis yet. You will not take marks for the social history and you didn't catch the diagnosis. Catch your diagnosis, answer the patient concern, you will get a great mark. Maybe not the full one, but great mark. But if you didn't catch this and you did summarization and you asked social and this stuff, you will not get more than half of the mark because you didn't catch your diagnosis. Okay? 6th question for migraine for the doctor is asking, please doctor, because of the time, if any doctor know the answers, please give him. I will answer this question, Dr. Asling. Unilateral or bilateral, any family history of migraine, any symptoms precede the like flushing of air, like strange sounds, this is for the aura, any feeling of sickness, throwing up, for nausea and vomiting, any photophobia and phonophobia, fear of lights and fear of sounds. Then I will ask about the period, the relation to period, lack of sleep, caffeine, alcohol, cheese, and oral contraceptive pills. These are the questions of the headache. For the clotting question, doctor, please answer him. Dr. Mahmoud or Dr. Ahmed, please answer them on the group of the questions. Okay? So this was doctor, this was our approach for headache, and this was our case today. Did you find that helpful? This is exactly what we are doing and how we are discussing our cases. When you practice that, my advice to you to go and catch this diagnosis, this page, just print it and take it with your colleague and pick a diagnosis. Take a diagnosis of CO poisoning, take a diagnosis of migraine, and let him start approaching the case by the same way. Once he catch it as migraine, okay, shift the rules and let him pick a diagnosis and keep practicing till you remember this page by heart. You will find that in all our algorithms, so by the end of our course, you will find that you are ready to face any case. And remember the page, and you will not need to open any other box to read more stuffs about headache and about this. Okay. Sometimes if you want to add something to your algorithm, as I said before, don't forget anything. If you want to add something, add it. But this is the common things and the common causes that will be the headache in your PACES exam. Okay. Do you think this is helpful? Do you get the point of the headache? Please answer me on the chat box. Okay. Thank you, doctors. Thank you. I will just give announce about we are holding our course every month, but we will not have a course. I think we will not have one in May because of Ramadan. So we'll have one in April. If your exam, I advise you to take it at least 1 month before. If 5 months before, 4 months before will be very helpful. The more time you have, the more time you have to digest all the algorithms and help you to be very ready. Alhamdulillah, we have doctors who attend 10 courses, 10 clinical courses, and they still they're still appreciating our approaches, and they attend with us, and they found the difference. Okay, we are 4 members of the course, me and Dr. Nada and Dr. Mahmoud and Dr. Ahmed. You will find a very organized course. You will receive material before the lecture and after the lecture, and you will receive the link of the lecture after the lecture. Okay, so all the details of the course will be with Dr. Mahmoud. It is very, very little price for 16 days. So just contact Dr. Mahmoud if you need details. Our course will be April 12th, and Dr. Mahmoud shared the schedule with you in the chat box if you want to be prepared. And there is a limited seats because we take a certain number, because we give everyone the chance to practice as much as they want. Okay,